Uterus disorders. Let's start first about the benign tumors. So we have the leiomyomas. I know that some of you recognize the word fibroids or myomas, but let's use the scientific word leiomyomas as a benign tumor that arises from a single cell that starts the division of muscle cells of the uterine wall and never stops. Leiomyomas are very prevalent in women, up to 80%. In the United States, by the way, it's not so high, but we have seen difference between ethnicity. So Black African American have up to 60% of leiomyomas in their uterus by the age of 50. In Caucasian women, they also present leiomyomas, but is about around 40%. Fibroids arises from a single cell, and it is a monoclonal cells that undergo anti-apoptotic changes. It divides, and it produces a tumor. This tumor is benign, even though we don't recognize genetic underlying. The etiology is multifactorial, which means hormonal, has a paper, cytokine stimulus, epigenetic changes, and also uterine environment. Talking about the pathophysiology, we know that leiomyomas are highly sensitive to steroid hormones. They also have receptors for both estrogen and progesterone. And some studies indicate that ovarian steroids like estradiol and progesterone can promote the growth of leiomyomas. Usually, leiomyomas decline their size after menopause, which because the hormones also fall in levels. This is a picture just to show you that where is the location of the leiomyomas. So we have the ones that are submucosal, like number 1 and number 2, right? It's a submucosal intramural. And we have a type that's pedunculate, that's number 0. We have other types like number 4 here, that's inside the myometrium, it's intramural. Number 3 has a little contact with the endometrium, but it's intramural also. Number 6 is a subseral, so it goes to the endometrium, but it also goes outside the uterus, okay? So those leiomyomas that are in contact with the endometrium are the ones that are going to interfere with pregnancy, or they're going to cause infertility problems. Those, like number 6, that are outside the myometrium are the ones that are going to cause other type of symptoms related to the pelvic cavity or abdominal cavity. So the consequences of a patient with leiomyoma, it's going to be abnormal uterine bleeding or heavy menstrual bleeding. That bleeding can be accompanied by pain and pressure. Bulk symptoms are the ones that I told you that it's going to be caused by the pressure caused by the tumor in the pelvic or abdominal cavity, problems with infertility, and also spontaneous abortion. Now let's talk about endometrial hyperplasia versus endometrial cancer. So for both of them, the risk factor is going to be estrogen presence. If we have a state of hyperestrogenism, that's a long-term exposure to estrogens, like the one that we have seen in polycystic ovarian syndrome, or in cycles of anovulation or late menopause, or the use of exogenous estrogens, That's going to be a risk factor. The other thing, metabolic syndrome, like the one that you have seen with diabetes, hypertension, and obesity, nulliparity or never been pregnant, increase of age, history of breast cancer, or any genetic predisposition, like colon cancer, non-polyposis, hereditary colon cancer, is also a predisposition for endometrial cancer and other syndromes like the Lynch syndrome or Codden syndrome. So the diagnosis is going to be done by biopsy of an endometrial sample, but also ultra or echosonography. Endometrial carcinoma, the main symptom is going to be abnormal bleeding. And this is going to be occurred approximately in 80% of the patients. And it's the most important and early symptom of endometrial carcinoma. Abnormal bleeding in a premenopausal person, menstrual history, intermenstrual bleeding, or irregular bleeding, or abnormal bleeding in a person that already didn't have vaginal bleeding, that didn't have menses, okay, in a postmenopausal patient. So, endometrial hyperplasia is a state of excessive proliferation of the endometrial cells that results from the increase of the gland versus the stroma ratio. Endometrial carcinoma refers to the proliferation of the endometrial cells that are capable in invading surrounding tissues and also metastasize to distant sites. The diagnosis is going to be through biopsy. Endometrial hyperplasia is a benign condition, and it could have atypia or not. Okay? So endometrial intraepithelial neoplasia has been used to describe the premalignant lesion of the uterine lining that predispose to an endometrial adenocarcinoma. Okay? So EIN, endometrial intraepithelial neoplasia. Endometrial cancer is characterized also by hyperplasia, but it has also anaplasia of the glandular elements and also has the capacity of invasion. Invasion under the stroma, the myometrium, and the vascular spaces. So, is it the atypical hyperplasia the precursor of endometrial cancer? Yes and no. So only approximately 25% of the patient with a typical endometrial hyperplasia are going to progress into an endometrial carcinoma, which means only 24% had a previous history of endometrial hyperplasia and then develop endometrial cancer. When we have an endometrial cancer, there are stagings. There are tumors that are confined to the uterus, and there are tumors that invade and go from the uterus to the cervix, to the part of the cervix stroma, or they go to the vagina, or they go outside of the uterus. So stage 3 and 4, they go outside of the uterus corpus, because still stage 2 is close to the cervix. So this previous classification is a simplified classification. This is the one, the FIGO stage in endometrial cancer, the one that you're going to go and use in ICM. It recognizes stage 1, 2, 3, and 4, but also has subclassification as stage 1A, 1B, depending on the amount or the length of invasion. We're not going to go over this.